Thank you very much, Madam Chairperson, Director, distinguished guests, ladies and gentlemen, good evening. First of all, I really want to thank Joe Mulholland for the invitation to return to Glenties this year. I believe the McGill Summer School serves a very important function as it allows us to debate key issues and discuss new ideas in a considered way, in a way unfortunately we don't often have the opportunity to do in the Dáil or in the Seanad or on the media. So I do hope that is something that we can do tonight, and I think based on the quality of the presentations we've seen we can, and it's certainly something we definitely need to do in health. When John Aloysius Costello approached Tom O'Higgins back in 1954 and asked him to become the first ever Fine Gael Minister for Health, the Taoiseach gave him a very firm instruction: try to take health out of politics. An instruction I suspect that has been given by Taoiseach to ministers on many occasions since. And of course O'Higgins, when he became Minister, understood the scale of the challenge. He had seen at first hand how the mother and child controversy had damaged the previous coalition, the first inter-party government. And he also bore witness to the power of vested interests, from professional groups to the religious to other bodies, who often cloaked themselves in the language of morality and tradition, and so frustrated even some of the most tepid patient-centred reforms. I'm just conscious that microphone is repeating. Are you hearing it too? I think it's probably because I'm too close to it. It's probably stopped now, has it? Or do we need to reboot? Are we okay? So I think when O'Higgins took over his job, what he particularly tried to do was to approach his job with a certain degree of skill and sensitivity. Among his most notable achievements were extending new and hospital special services to 75% of the population, bringing into operation the mother and child maternity service, and actually building many of the long-promised hospitals that his forebears only envisaged. Hospitals like Conley Hospital in Blanchardstown or University of Limerick Hospital, as we call them today. They had different names at the time. Perhaps one of his greatest achievements was the introduction of the legislation to establish the VHI, and he advanced money to the board to get that off the ground. And I think in many ways when I became Minister of Health a year and a bit ago, I took it upon myself to try in some ways to follow the example of O'Higgins, and once again to try and take some of the political heat out of health and thereby create some of the space, or some space that we need, for a reasoned appraisal of the strengths and weaknesses of our health service. What I've tried to do is to prioritise some really important and practical reforms over the past year. The most obvious one of those is GP care without fees for the oldest and youngest in our society on a universal basis. By universal I mean no means test and no sickness test. And to me they're just the first steps. They're the first concrete visible steps to universal health care. And I think it's something you have to tease out, this whole idea of means tests and sickness tests. I didn't understand medical cards at all until about a year ago. And I'm a doctor. I worked as a GP. And I'm a politician who dealt with queries from my constituency office all the time about medical cards. I had to become a politician, a doctor and a minister to actually understand the whole show, read the circulars, read the legislation and understand where it came from. And that wording is actually in the 1970 Act, but it did start its life in the Poor Law long before that. And something that struck me from what Orla said earlier on, and I totally disagree with her, but I understand where she comes from. And she says that medical cards should be based on medical need. And doesn't that sound like a great idea? Sure, of course it should be. You know, you're sick, you get a medical card. Think about what that means from the point of view of the politician and in practice. Most people in Ireland, 1.7 million people in Ireland, have a medical card at the moment based on a means test, based on their income. They're mostly people on social welfare, or people who are on low incomes, or people on relatively low incomes with big families. If you change from a means tested system to one that is based on medical need, we need to get all those 1.7 million people to prove that they're sick enough to deserve a medical card. And that might affect lots of people in this audience, and probably a third of the population. And I don't necessarily think that would be the right thing to do. And of course, when you do apply sickness tests, they're very difficult. It can never be just good enough to say that you're sick. You would have to have some sort of proof. And that's where the consultant letters come in, and the representations and all the humiliation that we put people through. So what we have at the moment is a combined system. We've a means test, an income limit. If you qualify with your income being below that, you get a medical card. If you're above the income limit, you can then make a case for a discretionary medical card. And that's where you're above the limit, but you have high medical costs or high medical needs, so you get a medical card anyway. And what we've done the last year is we've totally relaxed those rules. Every child with cancer qualifies regardless of their parents' income. Anyone with a terminal illness, pretty much anyone with a very serious illness or high medical costs. But they do have to go through all those horrible hoops, because once you have a test, there's a test. So a means test is a means test, and it's never going to be right, because there will always be people who are 5 or 10 euros above the threshold. You raise the threshold by 5 or 10 euros, it's just another group who are 5 or 10 euros. And if you do it based on medical need, well, then people have to go through a sickness test, and you have to tell them, prove you're sick, or you're not sick enough, or come back and apply again when you got sicker. So that's why sickness tests don't work. It's also why means tests don't work, and that's why I believe in universality. No more sickness tests, no more means tests. Everyone is entitled to healthcare on a universal basis, just like they are to education and to the state pension and to ETCHE and to child benefit and to so many other things. And the historic move that we've done with the under sixes is to break that principle into healthcare, possibly for the first time. The only time it was done before was with the over 70 medical cards, and we've got that now over the line. The last holdouts in South Tipperary sent in their contracts today, so we're now 91% of GPs have now signed up for that service. But it's all for nothing if it stops there. We have to go on to the next phases now, on to other children, children in primary school next year, ideally children in secondary school the year after, because I detest the idea that children are means tested on the basis of their parents' income. We don't do it for primary school, we don't do it for secondary school, we don't do it for childcare, we don't do it for child benefit. And it's really perverse, because what are you doing? You're saying to the parents that because you go out to work and you maybe earn 20 or 30 grand a year, that you have to pay for your children healthcare, whereas if for whatever reasons you don't work, you don't. And really, it was a big change, but something that is all for nothing if we don't now move on to the next phases, and particularly cover all retired people. And all children as well. And we'll be bringing in the over 70s next month, so anyone who's 70 years or older will qualify to see their GP without fees, regardless of any means test or sickness test. And again, people will criticise that. They'll say it's the 36,000 better off pensioners you're giving it to. But bear in mind who they are. They're the pensioners who probably paid a lot of tax during their working years, and they're the ones who maybe put a bit of money into their occupational pension. And what do we do at the moment? We say, oh, sorry, you put money into your pension, so tough, you shouldn't have done that. We're going to make you pay your doctor. So we're going to end that, and they're big steps, but they must only be the first steps to universal healthcare. The other thing that I've particularly tried to press ahead with as Minister is some very important and overdue infrastructure projects. The new National Children's Hospital being my particular favourite project. The planning permission for that will be lodged in a few weeks' time. I'm not going on holidays until the planning application is lodged. I've told my officials they aren't going on holidays either until the planning application is lodged. And if we can get that application in this month, we can have permission with the help of Bord Pleanála by December or January, and have that hospital under construction by February next year. So by the time we come back here next year, the National Children's Hospital will be under construction. The satellite centres in Tala and Blanchardstown, and the main special centre on the ground to St James's. And next year, of course, is 2016, and there's a really interesting programme to commemorate 2016. But I can actually think of no better way to commemorate 2016, or 1916 rather, than 100 years after the Rising, to actually make meaningful that proclamation, to cherish all of the children equally, and to begin construction of our National Children's Hospital on one of the battlefield sites of the Rising, the South Dublin Union, by this time next year. What I suppose I've also tried to do a little bit is to start to map out some sort of vision for the future. One that isn't grandiose, one that maybe isn't even ideal, but a vision perhaps that is politically deliverable, affordable, better, and visibly so. What few people may not have recognised is that rather than devoting all of my time and energies to firefighting or defensive actions, what I've tried to do is to gain some time and some space to get some things done. A health minister who is always on the defensive makes a very easy target for others, but is never going to be able to get things done for patients or for the taxpayer. So particularly the kind of things I've tried to get done in the last year or so, is to ameliorate patient safety issues, to deal in a meaningful way with hospital overcrowding. That's been largely around the opening of about an additional 200 community beds. We've also put a lot of investment into the nursing home support scheme. The waiting time for the Fair Deal this time last year was about 15 weeks. It's now down to 4. And that's particularly important because of something that Professor Hardyman mentioned, which was around the whole issue of delayed discharges, people in a hospital who are waiting for a nursing home or a home care package and are then inappropriately in a hospital bed, and as a result of that somebody else is on a trolley or a waiting list. The number of people who were delayed discharges in the country actually peaked around 850 back in December, January. We're now down around the 500s now, and just by doing that we freed up 300 additional hospital beds. So in Sligo, where I was today, you could count the number of delayed discharges in one hand, and the same applies to Letterkenny up the road. And my own local hospital has gone down from 40 to 25 in the last couple of months. But unfortunately, we have particular problems in particular places, and I'm sorry to say Beaumont is one of them. And in Beaumont, it's now not a lack of money, it's a lack of capacity. There just aren't any nursing homes in that area between Drogheda and Beaumont. But there is a solution, and it's under construction. That is now the new emerging problem in health. We didn't have the money for 7 years. Now when we do have the money, the capacity doesn't exist. Either the nurses aren't there, we can't get the doctors, or we don't have the space. And it's a whole new emerging issue in healthcare that has now replaced the problem of money, which is still a problem, but the worst thing is having the money and then not being able to spend it because you can't recruit the theatre nurse, or you can't recruit the doctor, or you can't actually find the bed space that you want the patient to go into. I do agree that we face absolutely enormous challenges in our health service, particularly in terms of equity and access. But I don't agree that it's broken. We have lots of problems, no doubt about that, and lots of things that we need to fix. But there are actually a lot of things in our health service that are going quite well and are getting better. And I do think we owe it to the people who work in the health service to allow some space to recognise that. Just to give you a few examples, improving life expectancy in Ireland, cheaper medicines than we had in recent years, because of the cancer strategy, improving cancer survival rates. Last year, I think it was last year. If it wasn't, it was thereabouts. We had the lowest ever number of deaths or disability from stroke, largely due to the stroke programme. Fewer heart attacks and almost nationwide access to primary PCI. This part of the country will be very familiar with the fact we now have an air ambulance, something we didn't have 3 or 4 years ago, and that was established during a time of enormous austerity, and now is a service that's been made permanent, and that gets people from remote locations to the specialist centres where they need to get to. We have the lowest MRSA infection rates in 10 or 15 years. We have very practical north-south cooperation that we didn't have before, and again, people from this county will be familiar with that. The fact that radiation oncology will be done in Derry for North Donegal, and primary PCI is done there as well. And we've also come from behind, where we were way behind other countries, to actually become world leaders in some areas. One is the treatment of hepatitis C, where we've made those drugs that cure hepatitis C available to more people more quickly than many other countries. And another example might be the area of bilateral cochlear implants. Some of you might have seen the documentary on RTE a few weeks ago into that, and that's something we didn't do a few years ago, but now we do. And I think, as was mentioned as well, we've had a major expansion of screening programs, breast check being extended to women aged 65 to 69, bowel screen, which some of you will be familiar with, a new service. Children now checked shortly after they were born to see if they're deaf or have CF. So there actually are a lot of good things happening. Despite the bad press and the very serious issues that have emerged in our maternity services, we do still have lower maternal and perinatal mortality rates than either the United Kingdom or the United States. And we have more midwives than ever before, and more consultant obstetricians than ever before, against a background of which birth rates are actually falling. So we'll get to international ratios not soon, but we will get there. We also have lower surgical complication rates than the NHS, and you're statistically less likely to die from a stroke or a heart attack in an Irish hospital than a British one. And while we do struggle to recruit and retain staff, and that's extraordinarily difficult at the moment, very hard to get applicants for some posts, particularly in certain parts of the country, actually there are 19,000 doctors now registered with the Medical Council, which is the highest in 10 years. So while there are people leaving, there are also people coming in, and there are also more people graduating all the time. And to be registered with the Medical Council, you have to pay €600 to them every year, so I can guarantee you people aren't doing that for the crack. We actually have more doctors in Ireland at the moment than we've had at any point in the past 10 years. You'll be forgiven for not thinking that's so. We have more consultants employed in the public service than ever before, and we're at the point now, having lost a huge number of nurses, where we're starting to bring them back again. We've 500 more nurses than we have. We've 500 more nurses in the health system today than we had a year ago. In Sligo alone, where I came from earlier on, there's 26 more nurses than this time last year. It's not being noticed yet on the ground, but they are there, and they're certainly on the payroll. And what we have lost is a lot of good people during the years of recession, and they were driven away. We did effectively say to our physios, our nursing graduates, and others, we don't have jobs for you. But we didn't, and we didn't have the money, and we had an enormous financial crisis. And let's not forget that. We lost 4 to 7 years in health because of that enormous financial crisis. But now the economy is getting stronger again. We have the opportunity now to turn that around. And just this week, the HSE announced its campaign to encourage nurses in the UK and overseas to come back to Ireland. They get a relocation bonus for doing so. Some of their higher education paid for, their registration fee, and some other things. So I think anyone who maybe follows public debates or discourse on health will be forgiven for thinking that our health service is very different. But those of us who know our health service, who've worked in it, and who care about it immensely, know that actually there are a lot of things in our health service that we can be proud of. There's much that we need to protect, and more importantly, a lot that I believe we can build on. When our chair this evening, Ruth Barrington, published her seminal study of health, Medicine and Politics, Ireland, 1900 to 1970, almost 30 years ago, she began the book with a very important question. This was 1970, bear in mind. How did we come to have one of the best health services in the world? I suspect if she were writing that book today or re-editing it for publication in 2015, she might ask a slightly more nuanced question. What has changed in the meantime? And I think to understand the problems that developed in the health service, we can be guided by 2 key studies written by May Van Ren, who spoke earlier, because they in many ways expose the political, economic and cultural forces that were at play in recent decades, as well as setting out some useful ideas for reform. I'm particularly aware of what went wrong in 2004 when the HSE was established. I remember well. I was a young county councillor at the time, and I was also a senior house officer in St James's. And Maeve Ann, in her book, How Ireland Cares, really tells the story very well. And she says the legislation providing for the establishment of the HSE, the Health Act of 2004, passed all stages in the Dáil in a guillotine debate in November and December 2004, without any time for many of the provisions to be discussed and fully understood, within or outside our Dáil, even by the government. Even by the government. I think that's an incredible indictment. Writing in 2006 with Dale Tussing, she also wrote that there was no white paper outlining the intent of the legislation. The policy operations divide between the minister, that's the department, and the CEO, the HSE, leaves great scope for confusion and blame. And the legislation is deficient in accountability. And I think in many ways they were enormously prophetic words. Some of the progress that we have made since 2011 has been very slow, but I think the caution has been justified, because reforms in healthcare shouldn't be rushed. I think that was the cause of many of the problems that happened back in 2004, and I'm determined not to repeat them. We've had enormous upheaval in health in the past 10 years. There have been 3 sets of structural reforms in the last 10 years alone. And as a result of that, many key posts are vacant. They're filled with newly appointed staff in newly created roles, or people who are interim or acting up. And all over the health service you come across interims and acting ups. I've never met so many people who are interim or acting up, and it's a really big problem. And by acting up, by the way, I don't mean playing up. I mean doing the role above the one they're actually being appointed to. And I think in some ways, to me, we don't have a broken health service. What we do have is something more akin to a ship that's damaged at sea. And ideally what you'd like to do with the ship that's damaged is you want to take it out of service for a while, put it into dry dock, and carry out a full repair. But of course you can't do that with a health service. With a health service, it's at sea, and you have to keep sailing. And therefore what you need to do is to repair the ship at sea. And that's extremely difficult. So it needs to be done over a period of time. Any changes we make need to be resourced well. We need to project manage them carefully and bring as many people with us as we possibly can. And I think what we all want, and this is where all the panellists, I believe, share the same vision, what we want to do is to bring about a universal health service that gives everyone timely access, but not just timely access, access to safe and quality health care for everyone. As I mentioned, the first major step on this road for us was the extension of GP care without fees to everyone under 6. It's about 270,000 children, and also everyone 70 and over, another 36,000 people in the next month or so. I do think, though, when considering a vision and a policy for the future, we should always start at first principles and start particularly with Healthy Ireland, which is the government's programme to improve public and personal health. It's the best way to ensure that we live longer, that we have healthier lives, and the best way long-term to tackle rising costs, to ensure that people don't get sick in the first place or put that off for as long as they can. We've made enormous progress when it comes to smoking in this country. Smoking prevalence has gone down from about 40% to less than 20% in Ireland. And I have two 5-year-old nephews, and I was with them a couple of months ago, and they saw a man smoking, and they asked me what the man was eating, because they had no awareness of cigarettes at all. And it shows how much things can change. And one thing I think we really need to move in that space, particularly, is the whole issue of alcohol. And I'm very keen to bring in our first ever public health legislation on alcohol. First ever, believe it or not, it's taken this long to have public health legislation on alcohol. Up till now it's been done through the licensing rules or something else. And that's going to be brought through the Dáil and Shannon. And I'm keen to get that through before the Dáil ceases and before the election. And also to publish new action plans on obesity and physical activity and sexual health. Another big important step is going to be building up primary and social care in the community. We've already expressed our desire to extend GP care without fees to all children in a second term, and I think that can be done. And I certainly can see no reason why we can't do it in the first 2 years of a new government by extending it to all children under 12 first and then all under 18 after that. We are also showing some good form in chronic disease. Better care of asthma is actually written into the new under 6 contract, and there'll be a new contract for GPs to treat diabetes in the community, and that's going to be issued this year, alongside better access for them to ultrasound and a GP minor surgery pilot. So I very much look forward to continuing discussions with the Irish Medical Organisation on further extending the scope of and access to general practice ahead of the March 2016 deadline that we've set for a new contract if possible. But I'm very keen that GPs and other primary care professionals, dentists, physios and others don't become de facto public servants. I'd rather that they not become employees of the HSE or whatever replaces it. I think one of the strengths of primary care in Ireland, of general practice, dentistry, community pharmacy, is that they're independent, that they are autonomous, and they're not controlled by a state agency. So what I'd like to do is to find a different way to cover adults who are not already covered, for their access to primary care. I think there are two options. The first option is using social insurance, using a reformed PRSI USC system to refund medical expenses such as GP visits and visits to the pharmacy and the dentists and therapists. I estimate that something as small as a 0.1% increase in PRSI would provide universal access to primary care for all working people. And we wouldn't even need that 0.1% increase, because with rising employment, falling unemployment and rising incomes, there will be enough buoyancy within the social insurance fund to fund that if we chose to do it. I think in doing so it could be a major step towards a single payer, a social insurance based system with payments to providers or refunds to payments administered through a new single payer. Another way of doing it, and I'd be equally happy with this, is to introduce universal health insurance for primary care initially, using a multi-payer system and giving people the option of either paying it through a social insurance contribution if they want to, or if not, to opt out, as is the case in other countries, for example, and stick with private insurance, provided their private insurance covers that. I'm particularly keen to expand the role of community pharmacy Pharmacists are enthusiastic to do more. They want to manage patients as well as dispense prescriptions. And I think we should help them to do more, particularly to manage minor ailments, administer more vaccines, do more medicine management and monitoring. And I also think we need a new scheme to reduce the out-of-pocket cost of medicines, which is now very high. It's €144 per month per household, and that is very inequitous, particularly on single-person households, where the 144 has to be borne by that one person. And we also have a prescription fee of $2.50, which I think is too high. I saw the cents in the 50-cent one, but $2.50 has got to the point now where it's putting some people off filling their prescriptions at all, which is a major worry of mine. So we are in negotiations now with IFA, the Irish Pharmaceutical Healthcare Association, on a new contract to buy medicines, and I think we should ring-fence a portion of those savings that we achieve to bring in a new cap, a lower monthly cap or a new annual cap for medicines, to reduce that enormous burden that some people have to pay for medicine. If you think about 144 a month times 12, it's the best part of €2,000 being paid on your medicines, and that's on your after-tax income. It really is a lot of money. We also need to continue to invest in the primary care centres. There's now 90 up and running. A new one is opening every month. It's impressive, but it needs to be sustained. And we also need to adequately resource home help and home care packages, which are not sufficient in many parts of the country, and they're really crucial for keeping people well and keeping them at home. When it comes to the hospitals, I don't think we'll actually really solve any of the problems in our hospitals until we address those deficits in primary care and social care. So many of the problems that occur in our hospitals occur because our primary care and our social care is underdeveloped and is quite weak. But when it does come to the hospitals, I think when you talk about funding hospitals, you really have to ask three questions about the money. First of all, is it enough? Secondly, is it spent well? And thirdly, how is it collected? Because an underfunded service is going to be a poor service, no matter how it's organised. And with current staffing levels of specialist doctors, 30-something neurologists in the country when we probably should have about 100, inadequate numbers of midwives, inadequate numbers of nurses, too few critical care beds, people still scrambling around the country looking for an ICU bed, I don't think any universal system would actually work well, because if you don't have enough capacity in your system to meet unmet demand, it's going to be a bad system, no matter how it's organised. And I think if we went straight ahead to universal healthcare system immediately in Ireland, what we'd really just end up with is everyone on a waiting list, albeit an equal waiting list, but everyone would be on a waiting list. And I don't think that would actually have much appeal to the Irish people. At the same time, no matter how much money you have, it'll never be enough if you don't spend it well and you don't spend it efficiently. And that's why I'm particularly determined to develop the autonomous hospital groups and the community healthcare organisations, and to place them on a statutory footing as providers of hospital care. They've already been established on an administrative basis. They need to be established on a statutory basis, and that effectively is the break of the HSE into self-governing hospital groups and self-governing local community healthcare organisations. It's just not possible to run the show either from the Department of Health or Dr. Stevens, and it was wrong of people to ever think it could be done in that way. Certainly when it comes to the hospital groups, I don't think that it's a case of one size fits all. Voluntary hospitals may wish to come together and lead their hospital groups. In others, new arrangements may need to be set up at group level. In some, they exist already. But it is, as I mentioned, my strong view that the current administrative setup needs to be put on a statutory footing, and I'm sure this could be done within the first 2 years of the next government. I'm also strongly of the view that hospital groups should be truly autonomous, to the extent that any body that's mainly funded from public money can be. And that means having board members who are not all appointed by the minister. They shouldn't all be ministerial appointees. And the hospital groups, or the trusts if you prefer, I believe must have the authority to recruit managers and specialists outside of the constraints of public sector rules in the way semi-state companies do now. So if you need to get that transplant surgeon and you need to negotiate an individual contract with them, so be it. If you want to get that really good manager from the private sector and you have to agree a package for them, well, then that is something that they should be allowed to do. They should also particularly own their own assets and be able to borrow against them if they so wish. But of course, along with greater authority will come greater accountability, including meeting healthcare standards as assessed by HICWA and delivering value in the use of public money as audited by the CNAG and subjected to the scrutiny of the PAC. The move to activity-based funding is a really critical reform, and it's actually far much more advanced than people may think, but will require a longer transition period given the huge variation in efficiency versus funding from one hospital group to another. We also need major investment in modern IT-based financial systems so that we can actually follow the money. And we need an electronic patient record so that we can actually follow the patient. At present, we can't do very well. And we've talked in the past about money follows the patient, and that's a good system. But if you can't follow the patient and you can't follow the money, you're really deficient in trying to introduce a system where money follows the patient. But the intention is that activity-based funding will replace the block grants that hospitals currently get, and therefore will incentivise hospitals and community healthcare organisations to do more work because they'll be paid more for it. That might be more hip operations, it might be more home health hours, it might be more dermatology clinics. But I do think that linking spending to activity is probably the biggest single reform that will make the most difference for the better in our health service from the point of view of patients and taxpayers. And I do believe that can be done in the term of office of the next government. It's ambitious. It took a lot of countries 10 years to bring in activity-based funding because it's a long transition period. We're 2 or 3 years into it. I think we could do it in another 5. At the top of it, what we need is a health commission to assess demand, allocate funding, and set models of care. That would achieve the split between the health purchaser from the health and social care providers, which was mentioned earlier, and allow health commissioners to get the best value for money, to essentially buy healthcare for patients on behalf of the taxpayer, and to buy it from public hospitals, voluntary hospitals, charities, NGOs, private companies. It doesn't matter so long as it's quality and so long as it's affordable. I think the Health Commission could be based on a reshaping of some of the existing expertise and responsibilities that exist in the HSE and also the NTPF, but also with input from new people who would bring in additional skills. We also need a health pricing office, which is now already established, but we need to establish that on a statutory footing to set particular prices for healthcare. One crucial and deliverable reform, in my view, which again could be done in a 5-year period, is ending any preferential access for patients with health insurance in public hospitals to theatre, admission, a specialist opinion or diagnostics. In a public hospital, health insurance should get you a nicer room or hotel-style benefits in a publicly funded hospital, but nothing else. As you know, we're a long way from the kind of health service that I've spoken about, and we're well behind many other advanced countries. And of course, there is a price tag attached to any new setup or any major reform of this nature. The funding required to bring about these reforms cannot and should not be taken away from frontline services. The reform process needs a dedicated funding stream of its own, which it hasn't had to date. The third question which I posed earlier was, how do you collect the money? Do you take it from tax, from social insurance, from health insurance, out-of-pocket payments, or some sort of combination? And actually, having looked at the evidence, and to the extent that there is evidence, I don't find any compelling evidence to favour one collection system over another. Australia, a pretty good health service, has a 2-tier system, very like ours in fact. But because access to public hospitals is timely, and because the most complex and special centres are in public hospitals, people really only take out health insurance in Australia for those hotel-type benefits. But even still, they do so in very large numbers. They have a 2-tier system too, but the 2 tiers are around the quality of room you're in, not necessarily the quality of healthcare. In Britain, their health service, you know, is almost entirely tax-funded. That provides timely access and also reasonable outcomes. But even in Britain, a proportion of people take out private health insurance, mainly with Bupa. So even though we don't realise it, Britain with its NHS actually has a 2-tier system too. It's just a smaller portion of people who choose to take out private health insurance. And it's a very different type of 2-tier one than the one that we have. The Dutch system, which we mentioned earlier as well, is very high on quality. It's also very high on cost and operates under a multi-payer compulsory private insurance system, but with enormous tax subsidies. Germany does it different still. France does it differently again. And in fact, every country does their health service differently. So whatever solution we have for Ireland is going to have to be different and unique to Ireland as well. There isn't some model you can pluck from another country and impose in Ireland and expect it to work. That isn't going to work. But the ones that do work well, in my view, don't work well because of the way they collect the money. They work well because they collect enough money and they spend it right. And they're the two things that we need to get right, crucially, in Ireland. So we need to have adequate funding and adequate staffing, sufficient numbers of specialists, sustained investment in health and well-being, universal primary care so that people stay out of hospitals, much stronger social care so they can get out of hospitals, autonomous statutory hospital trusts and community healthcare organisations, activity-based funding, and a health commission with the purchaser-provider split. Earlier today, as I mentioned before, I came here from Sligo, and as you know, this year we marked the 150th anniversary of Sligo's great poet. W.B. Yeats believed that it was easy to get lost in the labyrinth that we make in art and politics. And over the past 30 years, we've made health into a labyrinth, a maze to confuse and trap. To light the way out of our current problems, we need a realistic vision and the time and determination to follow it through to the end. In the next 5 years, with a political mandate behind us and a strong economy behind us to finance it, I believe we have a new opportunity to do exactly that, and it's something that I'm determined to do. Thank you very much.